Hello, my name's Shireen. This is the second in a series of lectures on anaesthesia. Today we're going to focus on the pre-operative assessment of patients before an anaesthetic. I'm going to run through basically what I saw happening at my hospital. Obviously, every hospital have different ways of doing things, but generally the principles are the same and much of the same questions are used in the assessment. So essentially, up to 2 weeks before an operation, a patient would come to pre-assessment clinic where a nurse would run through a series of questions and a survey with a patient where any issues may be flagged up. During this clinic, a consultant anaesthetist is present for the nurse to go and ask if they were concerned about anything. Where concerns are raised, the consultant anaesthetist would then see the patient, run through these issues, and then decide whether or not the operation would be safe to go ahead and if the anaesthetic is safe. So the operation would either be cancelled because the risk of the anaesthetic would outweigh the benefits of the surgery, or the anaesthetist would go on to discuss the case further with the surgeon and perhaps come up with an alternative form of anaesthesia, for example, a nerve block or a local anaesthetic, if the risks of the general anaesthetic were too high. Generally, most of the patients that I saw were fit and well, and there were no issues. After the pre-assessment clinic, and when the patient's been accepted for the operation, they go home and come back on the actual day of their operation. They'd stay in the surgical reception in the morning, and very early on the surgeons would come down to consent the patients, and the anaesthetist would come down to run through a pre-operative assessment, which is what I'm going to go through with you today. So this is an example of the preoperative assessment form. As you can see, it's all on one page, a very easy layout, and it just kind of encompasses the main points involved in anaesthetics. So what I'm going to do today is just run through all the different parts of this assessment sheet and discuss why each part has its own specific importance. So first and foremost, with all things in medicine, documentation is vital. These are all legal documents, so 3 points of identification must be used: the patient's name, the hospital number, and the ID. If no stickers are available, you write it down, but these 3 points should be on there, and it's a very big topical thing at the moment to constantly be checking the patient's name and ID as they go through the operative process, with name bands, with the WHO checklist. Going on to the next bit, so basic observations are performed in the morning by the nurse. So you'd want to know the patient's heart rate, blood pressure, and temperature. On the day of the operation, the patient must be hemodynamically stable. As I said before in my previous lecture, the anaesthetic drugs tend to drive down the blood pressure. So a slightly higher blood pressure is not always a bad thing, but by and large, the patient needs to be stable. Height and weight, they're much more important in paediatric cases where the dosage of drugs need to be very carefully measured out, less so in adult cases. Okay, fine. So the next part of the assessment is to ask the patient what operation they're having. This seems quite obvious. Obviously, the patient knows what they're having. The surgeons know what they're having. You've been told what the patient should be having. But it's also a good opportunity just to double check things with the patient. You can never ask too many times. And quite often I found it gave the patients the opportunity to ask a couple of more questions that maybe they didn't have time to ask the surgeons, maybe they forgot to ask the surgeons, and so they can ask the anaesthetist. And anaesthetists tend to do the same elective lists week in, week out. So they know quite a bit about the surgical part of the whole procedure as well. So the next point that is used on the assessment is looking at the ASA grade. ASA stands for the American Society of Anesthesiologists, and this is a grading system where a patient's given a number between 1 and 5, and this basically looks at their pre-operative health. So someone who's grade 1 would be a completely fit and well adult, no medical conditions, absolutely fine. Someone who's grade 2 has some mild systemic disease, but it doesn't really affect their life at all. And for example, someone who suffers from, I don't know, hay fever or eczema, something like that. It should be noted that all patients who are aged over 80 are by default put into a grade 2 category just because of the risk of the operation for them. Grade 3 is a severe systemic disease that causes a limited amount of effect onto their quality of life. So, for example, something like COPD. Grade 4 would be a systemic disease which is much more effective, much more detrimental on their quality of life, and it's a constant threat to their life. And grade 5 would be a patient who's essentially moribund and they've got very, very high risk of mortality from the anaesthetic. Generally, for elective cases, the patients that I saw were grade 1 or grade 2, and occasionally a grade 3. Urgency that you see here, it just basically refers to if the operation is going to be elective or an emergency case. So again, taking a past medical history and a drug history from the patient. Past medical history is very important for conditions such as rheumatoid arthritis, where 90% of patients have some form of neck involvement. So commonly in rheumatoid arthritis, patients may suffer from atlantoaxial subluxation, and during the intubation process, their head is quite hyperextended, so this can become an issue. Other things, for example, obstructive sleep apnea, if the patient's on CPAP, you'd know that intraoperatively, from the anaesthetic point of view, they may have a difficult airway, there may be issues with hypoxia, if the patient's lying flat, there'd be issues with patients if you have to put them in the steep head down position. These are all things that would basically raise alarm bells, and all anaesthetists do consider. Drug history, again, this is important. What medications is the patient on? Some medicines, they need to be omitted before surgery, some omitted after surgery. If the patient's on a huge host of analgesics of chronic pain, this means that they've probably developed tolerance to a lot of the drugs that you'd be planning on using for the operation, and pain would be an issue. Most hospitals that I've seen have a dedicated pain team, which would be called to address such issues. Previous anaesthetic history. So has the patient had an anaesthetic before? How were they after the anaesthetic? If they haven't had an anaesthetic before themselves, have their family had an anaesthetic? Any problems with the family having the anaesthetic? Because quite commonly these things do run in families. So this again would give the anaesthetist a heads up. So commonly a patient may say, I wake up from the operation shaking, shivering, very, very cold. So the anaesthetist would know just have an extra blanket ready for them to, if they haven't already, to use a bear hugger in the operation. Or the patient may say, for example, last time I woke up and I was just vomiting non-stop. So again, the anaesthetist, they would know just to give them an extra antiemetic, or if they weren't planning on using an antiemetic, then they would use an antiemetic in such a case. As with all things in medicine, alcohol, tobacco, recreational drugs, we ask it in all medical histories before anything that we do. So importantly from these points, tobacco, often you'd ask a patient, do you smoke? They'd say no. Say, did you used to smoke? They'd be like, yes. You say, when did you quit? They say 5 days ago. Now, actually, it's been shown that quitting just days before your operation actually has an adverse effect from the respiratory point of view on you. So the best thing to do is either be a complete non-smoker, or if you're an ex-smoker, to be an ex-smoker from months, if not years before. Recreational drugs, again, very important. If the patient's a heroin addict or an opiate addict of any sort, then the morphine that you're going to give them is not really going to touch them, and you're going to have to give quite a whacking dose of it to get some pain control post-op. Again, all this assessment is doing is just raising issues that the anaesthetist should think about during the whole operative process. Also, one other point on that was allergies, which is very, very self-explanatory. Whilst asking about allergies, I often used to ask about non-steroidals. I'd say, are you okay taking aspirin, ibuprofen? Because again, this would give indications for post-op pain control. Plain dentition. So ask all patients, do you have any loose teeth, caps or crowns? And the airway, this is used to basically determine the ease, potential ease or difficulty intubating a patient. So the tool that's I've seen most commonly being used is this thing called the Malin-Patty score. This is where a patient's given a number between 1 and 4 based on when they open their mouth and stick out their tongue, what you can see. So if you can see the whole uvula, they'd get a 1. If you can see part of the uvula, they get a 2. If you can't really see it, if you can see the soft palate, they'd get a 3. If you only see hard palate, they'd get a 4. So quite self-explanatory. If they're a 1, they're going to be very easy, theoretically, to intubate. If they're a 4, they're not. A lot of controversy exists as to the actual usefulness of the predictive value of this test, but it is done routinely. An addition to this would be to add on an A, B, or C onto the patient's Malin-Patty number. So, for example, if the patient is unable to bring their lower teeth in line with their upper teeth or in front of their upper teeth, they'd get an A. So they'd be, for example, a 2A or a 3A or a 1A. Or if they can bring their lower teeth in line with their upper teeth, but they can't bring it any further forward, this would be a B. So there'd be a 1B, 2B, etc. If they could bring their lower jaw right in front of their upper teeth, they'd be a C, which is great. You'd want the patient to be a C. So all patients need to be examined before the operation. So cardio and respiratory are the most important systems to examine. Cardio, have they got any murmurs? Any murmurs, if it's an elective case, need to be investigated before the operation. Respiratory symptoms, have they got any crackles, any signs of any active infection? Again, you'd want to avoid doing an operation in a patient who's already got an infection in their lungs. Now coming on to investigations, ECGs and X-rays aren't routinely done in anaesthetic cases unless there's an indication, so previous cardiac history for the ECG, or mainly if patients are above 60, they'd get an ECG as routine. But if they're less than 60 and perfectly fit and well, you wouldn't really bother. X-rays, these are usually done from the surgical point of view as part of the surgical workup. But for example, as we spoke about before, if someone's got rheumatoid disease, you might want to do a cervical X-ray just to have a look at their neck. And others can be anything that would be relevant to that specific case. All patients require blood tests, so you want to do a blood test looking at the hemoglobin level. If the patient's anemic, this would increase the likelihood of intraoperative hypoxia. You'd want to look at things like the clotting if the patient's on aspirin or if they're on warfarin. You might want to group and save if the HB's quite low, or if, for example, you're thinking that it's going to be a great amount of blood loss in the procedure or the operation. And another thing that's quite important is looking at the user needs, because this would kind of tell you, can I use non-steroidals post-op or should they be avoided? How important fluid management be? How vital would it be post-op, essentially? I mean, it's important for all patients, but more so if they've got renal dysfunction. And then finally, it's just a discussion with the patient. So this is the opportunity for the patient to ask any further questions that they may have regarding the anaesthetic. Usually I'd use this opportunity to run through the risks with the patient, risk of a tooth being knocked out, the risk of them waking up in pain, but I'd assure them that we're going to be prescribing them an adequate amount of analgesia, and they just have to ask the nurse if they're still a bit in pain. And also, I'd warn them that with the tubes that we put down the mouth, they may get a bit of sore throat post-operatively. If the patient's having anything special, for example, a spinal anaesthetic, I'd run through, or a nerve block, for example, I'd run through the risks associated with them as well. And as I said before, it's a legal document. Clearly, put your name down, your grade, you sign it, and you date it. So that's basically looking at the preoperative assessment from an anaesthetic point of view. As you can see, they're all very, you think they're basic things, but they're all very, very important things to consider, and they all give the anaesthetist vital clues as to what the patient may or may not need pre-op, intraoperatively and post-operatively.